All right, welcome back to another PCBH Corner. I'm so excited to have Stacy Ogbeide joining us today. And I think a lot of people know Stacy and Dr. Ogbeide because she's involved in everything and anything that's related to PCBH and education of future BHCs or family medicine residents. It just is has so many different things that she's involved in that we're going to talk about today. The one thing that I always like to point out that a lot of people probably don't know is that Stacy and we went to grad school together. Stacy, myself, and Bridget. And I always make the same joke. Stacy was a year ahead of us in our grad school program. And I like to think that Bridget and I are busy. Stacy is without question a lot more busy. And from the beginning, I remember thinking of grad school and seeing this second year grad student just being involved in everything and being so dynamic and so involved. It was just inspiring. So my gratitude, Stacy, for always doing that. But do you want to take some time to introduce yourself real quick?
Sure. So, well, you know my name. You can see it there. I am a health psychologist, clinical health psychologist by training. I am at UT Health, San Antonio in San Antonio, Texas. And I do a couple different things. I work with family medicine residents. I direct our behavioral health education curricula for them. We have a primary care track within our psychology internship that is in the psychiatry department, and that I coordinate that track. I also co-chair our professional development committee within our Department of Family Medicine. So faculty development for all of our faculty, our psychologist faculty, physician faculty, pharmacist faculty, PA faculty, and so helping them become even better faculty. And then we have a HRSA grant that is with our sister institution, UTSA. We have the Health Science Center and then the main campus. So main campus houses a master's program in clinical mental health counseling. So I help direct that, co-direct that curricula on primary care behavioral health, so we can have some future BHCs come and join us. So a couple of different things. I'll stop there.
I almost want you to keep going, because as you were saying, with most of the PCBH corners, Stacy and I were just talking about this off camera, that we have specific topics that we try to talk about, but we do want them to be genuine. And as you were saying, I was just writing down a bunch of different things I do want to ask you about that well in my question. So we'll see how this goes. But yes, I mean, involved in so many different things, which my mind almost says is like kind of the reflection of primary care, that there's just so many different things to get involved in.
Right.
And whether it be I wanted to ask you about, you always had an interest in pain. You were even in grad school, you're way ahead of the game and trying to work with pain and sleep, and then, but also these variety of different professional and educational roles. So let me ask you this.
Sure.
First question. I mean, can you talk a little bit about what got you into primary care and what got you into all these different areas that you're involved in? Where does this mission come? Where does this value come? Where does this passion come? And what was the journey?
Yeah. Honestly, the individual that got me into primary care is an individual that we both know, Chris Newman. Yeah. He was our faculty member and directed our primary care track at our doc program, because I came into the doctoral program solely focused on traditional health psych. So
even before going in, you knew you wanted to go to health psych.
I know I wanted to do clinical health psych. That's what I wanted to work in cardiology. I still love the cardiac work to this day. That's one of my interest areas. And so I plan to work in cardiac rehab, working with those patients. That was my plan. And in undergrad, the research I did with one of my health psychology faculty was cardiac rehab related research. And so that was like, okay, I love this work. I love the impact of behavioral issues on, how someone recovers after a myocardial infarction, people with different types of cardiovascular diseases, how psychological factors are so strong and the research is so strong with that I said, I really want to do that. That is so fascinating. And so I came to the doc program, and our program had a pain management track, which I was already in. I was planning to do that. And then Dr. Newman said, "Hey, have you heard about this thing in primary care?" And I said, "No, but I know what primary care is. I have my own PCP. Tell me about it." And he was talking about primary care. He was essentially describing the 4 C's of primary care to me in our numerous conversations. And then he said, "You can do health psych work in primary care. You don't have to be in specialty medical settings. That's not the only place to do that." So after that, that's pretty much where
Wow.
my transition changed. Dr. Newman got me involved with some research project he was doing as a first year student. And since from then, I was sold.
That's amazing. That really is incredible, and especially as you said, and I would imagine it makes me think of Chris Hunter when we interviewed him, and how he was saying definitely like this huge health psych and this huge behavioral medicine
Yeah,
focus, and how primary care is just the place that almost like all that is realized,
sure.
and then some. So as you said, like the cardiovascular stuff, and then the pain and sleep, and I mean that
Right.
it's all in primary care. That's really really interesting. Related to that, one of the things I mean, there's a lot of things I admire about you. One of the things that I really have always taken to heart and admired is this willingness and this want to be evidence informed, to be up to
Yeah.
date on literature. Can you speak to that? One, my mind goes two ways. One is like, where does that come from?
Sure,
What
sure,
has been that inspiration to do? And then two, what do you tell your students? What do you tell your BHCs, even maybe your residents, on how to stay up to date on stuff effectively?
sure.
So maybe where does that come from? That passion, that mission, and then also how do you advise? How do you suggest people continue to stay up to date on these variety of different things that do
Sure,
show up in
sure.
primary care?
Honestly, I think that was instilled from a very young age to always do your work to the highest standard
Right.
possible.
Right.
I come from a traditional Nigerian family, and so that's it was more of a just an expectation. It wasn't necessarily a choice. It was just how you carry yourself, and so I carried that into my schoolwork, my extracurriculars growing up, and then followed me all the way through into graduate school, where if I'm going to do something, I want to do it well and serve the individuals that are receiving that service well. So it came from there. And then it wasn't until graduate school that I realized, because one of my other passions is working with marginalized
Mm,
populations and finding that marginalized groups, if they receive care, any type of health care, chances of it being evidence-based are quite low.
mm,
And that really struck me. Someone who is part of couple of marginalized groups, to know that, okay, the care that I get may not be evidence-based, and why is that? And there's lots of reasons on the why. I won't dive into that, at least for now. But that in and of itself really pushed me,
mm,
because of the groups that I work with are underserved and marginalized, to give them care that they deserve. And that is good care. Just because you are coming to get care at a community health center or a county health clinic does not mean that you get subpar care or care
mm,
that is not evidence-based. And so that was one of my missions since graduate school, to always give people the care that they deserve. And
mm,
then through that, I always instill that in the trainees and learners that come through my clinic, is that we do evidence-based care here, and here's
mm.
why. And I'll share the data of why this is important, why particularly the populations we serve who are underserved and marginalized don't get that care, and what they can do to mitigate things like bias and racism and things like that. So that's something that's always been important, for a few reasons that I shared. And that's a value of mine. And so it's something that I can live out and walk through every day, that I get a chance to work with populations.
So it gets me hyped for a variety of different reasons. I mean, one, as you said, the beginnings of it, this is a family value. This is something they kind of growing up with and instilled with, and how beautiful that is. And then I love how you're framing this, that, yeah, hey, good medicine, evidence-based medicine, let's do that. That makes a lot of sense. However, it sounds like this is more tied to this value of, hey, I have a value of serving people that don't get access to care, and I'm damn sure going to make sure that they have access to evidence-based medicine and how to do it. That's amazing. And you talked about that in our pathway conversation. I remember, and particularly one of the benefits of having pathways is almost like these guardrails to ensure that everybody, regardless of who they are, is getting the evidence-based medicine.
Absolutely.
Yeah. That's great, Stacy. That's really cool. That's really cool.
Yeah.
Awesome. It made me think, one of the, as we were saying, Stacy has so many different, things that she's involved in. And one of the research I would love for you to talk a little bit about, and again, I'm totally not paying attention to our questions that we had for.
Not a problem.
But one of the research studies that I love that you did, and I would love for you to maybe talk on it for a little bit, is the study that you did, that you talk to people that access PCBH services, and after the fact, ask them. And what did you ask them? You asked them if they would have gone to like a traditional. And what did you find?
Yes, we did a study where we compared our population we work in a FQHC lookalike, essentially a county health clinic that where our residency is, and we compared our data to the data from the military. San Antonio is a big military area. We have a lot of bases here. And so the Air Force Base has a PCBH program that they call the B-HOP program. And so we asked their patients the same thing. And we found that essentially we had said, if the behavioral health consultants were not embedded in the fabric of your primary care clinic, and you were given a referral to go see someone outside of our clinic, would you go? And about 87% of our patients said no, they would not. And surprisingly, because half of the study was with my military colleagues, about 67% of their patients said no, in a system where it's relatively much easier to go to a specialty mental health provider. You can be seen in a short time frame. There's not this confusion of where do I go, and still more than half of their folks still said no, I want care in primary care. So that was very powerful for our clinic, our health system. That helped us hire like 2 more BHCs in our clinic. We took that to our leadership and said, hey, look what our patients said. They said they're not going to anywhere else. They want care in their home, which makes sense. And so that was a project that came out of a quality improvement project. We just wanted to see how we were doing. And then conversations with our military colleagues came out and said, well, let's put this together and publish it. And so that was a really fun project. And we're actually in the process of doing the same thing with our pediatric populations, because we did the initial project with adults. So now we want to ask our kiddos and families similar questions. We have some additional questions we'll ask the parents. We want to get a sense of that for our pediatric populations that we serve too. So we just got grant funding to do that project. So we'll be collecting data this summer on that one.
Incredible. And but as you said, I mean, even though there was a difference between, what was it, 83, 87 to 60 or so.
Yeah.
Still, I mean, even though obviously one is more than, it's still showing that it's like most people are not going to go to even a referral is made. Even in a system, as you said, that's such a great thing to point out, even in a system that maybe has easier access than what the general population does because of being a closed system. That is interesting. That is really interesting.
Yeah,
so let me ask you this. I mean, you kind of subtly touched on this throughout what you were just discussing, and I'm always interested in particularly asking the leaders of PCBH as you are, and these people that are just doing such incredible work in the field. I'm sure there are people, I mean, I'm one of them. I mean, I'm sure there's people on the listserv that are like, I would love to do what Stacy does. I would love to be able to be involved in all these different things, and be motivated. And what my mind predicts, other people's minds are saying, it's like, it just seems such like a big thing, like such
Yeah.
such big things that just are difficult to do. So if you were given advice to any maybe students out there or
Yeah.
any professionals that are involved in CFHA or any of the other organizations that you're involved in,
Yeah.
what advice would you give if, I know this sounds so corny, but if they were like, hey, I want to be like Stacy, like what, literally though, what
Yeah.
practical advice would you give them?
I would honestly have them take a step back, and whether you write this down, some people do uh, diaries where you're recording yourself and listening. However you do your self-reflection journals or whatever it is, I would encourage. And if you don't do one, I'd encourage you to start one.
Cool.
If you don't, is to write down what your professional values are, your personal values, and know what those are through and through. And if they're true values for you, it'll come out naturally. Not necessarily, they're not forced. They're not someone else's values. They might be family values that you carry, but figure out what they are for you. And then use that as your lens of what you say yes and no to. That's something that I have done for many years. I do a lot of different things, and I still very much and very often say no to a lot of things because they aren't aligned with my values right now. It could change in a year or two or 5 years, and I might pick that project up. But at the current time, they're not consistent. So I say no, or not yet. Sometimes I might tell someone that sounds like an awesome project. That's not for me right now. I might give them some suggestions for who would be great, but not me. So I would say figure out what your professional and personal values are, and honestly work through that lens, because the work that you do through that, even though it's a lot of things, there are days when or weeks that it's 80 plus hours a week that I'm doing. There are things that I enjoy. There are things that are meaningful. They're going to change someone's life. Even if it's just one person, I'll take it. If I can help build confidence in one student, I'll take it. If I can give one patient access to care, when you hear those stories, I hear it a lot in our well child clinics. We'll be consulting in well child, and I'll be working with the family, and a parent says, man, how come you weren't here when I was here? And I said, and I'll tell them, well, we're here now. And if you're not a patient of ours, can I walk you through how to become? So we have a lot of, and I'm sure people have this too, we have a lot of parents in our well child clinics who will become patients of ours because we're family medicine. And so just little stories like that can inform what you do. And so it doesn't necessarily feel like work with some of the things that I do. It's tiring, of course, because it's hard work, but it's good work that will have this nice ripple effect on communities and learners that you work with. So that's the place that I would say is starting with what is it that you value? What is it that you value professionally? If you're thinking about going into a position, do your values fit with what they put on their website, their mission statement, whatever that. If you don't know their mission statement, look it up. Make sure that and what they say, does that match? Many times organizations have a mission statement, and then you're there, you're like, this has nothing to do with what you say you value. So look at those things because it matters. It really does matter, especially on the days when you're like, why am I doing this? Should I even be in primary care? I'm tired. When you can plug it back to things that you value and that you're making a difference in someone, even if it's just one, it counts for sure. One person's experience, that's incredibly meaningful. So that's what I would say.
Oh, it got me hyped. That got me hyped in so many different. I honestly, Stacy, like that, and this is something I think these are. I just love being able to do these PCBH corners because I get to learn all these different things and still them. I mean, it's mostly just for Bridget and I. This is completely selfish that we get to do this, but the thing that I love, obviously, the first thing, as you said, like start a journal, and I remember hearing that, and it was actually Bridget who was just like, Dave, you need to do something, like you need to do a planner or something. I just remember that. Come on, stop it, like that's corny, and I've done one now for like 2 to 3 years, and it's absolutely changed my experience. It really is incredible. So starting a journal, as you said, doing the personal professional values. And I love how you said allowing them to direct yes or no. Am I going to get involved in this? Am I not going to get involved in this? And the other things, the 3 things that I wrote down that I really, really love, and I hope people watching this really, really embody, is the one is that it's going to be hard.
Yeah.
There might be, as you said, like 80 plus hours in a week that you're doing it. There's no question. I think that's something that when people see, it's not an accident that Stacy does as much as she does because she puts in time for it, right? So it's going to be hard. And to make sure, it sounds like, as you were saying, in the moment, celebrating wins, when you do get to talk to a person, that's like, why wasn't, I wish you would have been here. I remember an MA told Bridget that before. It's like, man, I wish you all would have been here when I was growing up, like what that would be different. And I love what you said about the organization, to make sure the organization aligns with your values, and having that Stacy, that was that got me hyped. That got me hyped. Let me ask you this. You spoke to this a little bit. Is what are you working on right now? What do you see? Over the next a couple months, a year. What are the projects that you're really taking on?
A couple of different things. Of course, always a few different things. In the realm of workforce development, that's been another passion of mine, just because you, myself, Bridget, all of us will be in primary care for some time, but not forever. We want to go do other things when we retire. And so
got a lot of golf planned.
Right, exactly. A lot of golfing, a lot of traveling, And so we need good people who can pick up the work, pick it up and keep it going. And so I have a few projects related to workforce development. One of them is a paper that we got to work on with Bridget Beachy on kind of the current state of primary care behavioral health supervision in the context of publicly funded health centers. And so that should be coming out soon. So for anyone who supervises behavioral health students in primary care, this is for you. Anyone who's thinking about supervising, this paper will be for you. So that should be coming out. And then the past 4 years, the HRSA grant that I've worked on with UTSA, we're putting out some of the outcome papers that we, the stories that we've learned over the years. And so 2 of them will be coming out soon. One of them has to do with the impact of self-reported competencies, the BHC competencies, and how learners see their growth over time based on those BHC competencies, and what training programs can do to be creative with how you teach these competencies in the classroom versus in a clinical setting. And so we have that coming out. And then also we have one that I'm most excited about, where we looked at how the clinical learning environment impacts competency development for learners. And so we looked at levels of integration for different clinics. And so we looked at essentially how integrated is team-based care and behavioral health consultation, how embedded is it into the fabric of your clinic, and how embedded it is will impact the learner's outcomes and how they view themselves as a BHC, their professional development into becoming a BHC, as well as just how they view themselves as part of the primary care team. So that one, I'm absolutely
I'm pumped about that too. Dare we say the context and how that influences that? No, that is, I'm excited to see what the results
context
are.
Matters.
Right.
About that paper, context matters. And so the big takeaway for that one is, if you're thinking about hosting a student, get your house in order.
Oh,
before you bring a student on. If you are just, if your clinic is new to integrated care and you're really excited and you want to get a learner there, just pause for a second and wait to see, do we have our ducks in a row? We're not asking clinics to
amen.
be perfect. We're asking you to, whatever clinic flow you have, know it. So a learner is not coming in there completely confused. So that paper, oh, I'm excited about that
Oh,
one. So
I'm
that should be
excited
coming
about
up.
that too. Oh my
That should
gosh.
be really, that'll be really, really good. The other papers I have coming out, the other one I'm excited about all of them, I guess, is primary care behavioral health supervisor competencies.
Mm,
That was something that came out of just my own experiences being a supervisor. As you work with psychology interns as well, for those of you who aren't familiar, interns, they're in their final year of doc training before they have their doctorate. So they're at their tail end of training. And when I have learners who are coming in saying, okay, I have primary care experience, I'm like, oh, great. That'll save me some time. We can dive into other things. And then sure enough, they would match, they'd come to our clinic. And then I find that they really were just doing co-located
yeah.
care. They have no idea what primary care is. They don't know what a medical assistant is. I mean, it kept happening over and over and over again to where I said, what are people doing? What are these supervisors doing? Because we are not on the same page with what I think you should be doing versus what you think you're doing, because these learners are coming out and they cannot function in primary care. So that's a problem in my eyes. So this project honestly came from that, over years and years of having learners who don't know how to work in primary care. And so we don't have competencies that are specific to supervision in primary care. We have the BHC competencies from Robertson and Ryder. We have some of the other competency work that the Center for Integrated Care through the VA has done, which are great, but they're for the clinician. But there's nothing specific to, if I'm supervising, what do I need to know to make sure my student is well taken care of, that I'm doing what I need to do that's evidence-based. And so we just wrapped up this project. The manuscript draft is complete. We're going to submit it this summer. We just got word we get to present it at CFHA in October. So please come to our talk to hear about these competencies and the behavioral anchors that our subject matter experts identify for us. That project is awesome. So I'm really excited to give the workforce and supervisors guidance on, here are the things that you really need to be doing if you're working with a pre-licensure level student in primary care. So those are a couple of things that I'm working on right now.
Yeah, I mean, there's no wonder that you're excited about them, because I'm getting excited about them right now. And I could not, Stacy, oh my gosh, I could not agree more with what you're, saying. I was talking to our trainees about this, and it's the same thing every interview season. It's like, yes, I want people to have previous experience in primary care for sure for our internship. I will be completely honest. I hold that very, very lightly when I get some, right? I get someone like, oh yeah, I have. It's like, yeah, okay, yeah, we'll see.
We'll see.
Yeah. But no, man, that is awesome. That is really, really cool, and I love that. Get your house in order. That is that gets me excited. So so two last questions, because this has been great. We'll probably have to do part two, because my mind has a lot of different for the sake of people watching and the viewing. So we might do part two. But last two questions I have for you. And you mentioned this a little bit, CFHA coming up in October. Yeah. What are you looking forward to the most about CFHA in October in Boise?
Just being in person.
Right.
Yeah. I mean, I don't have some, revelation to share. It's really just, I'm excited to meet and talk with people in person. I got the privilege over the past few months to go to a few other conferences that were in person. And it was amazing. It was great. It reminded me of what we haven't had for 2 years, about 2 years or so. And so knowing that these other conferences are great, but they're not the same level as CFHA in person. No offense to the other conferences. But CFHA is just, if you've never gone to CFHA, especially if you're a learner watching this through COVID, go. It's just a different experience. We have just so many just side conversations that are so life-changing. I love staying up till 2 a.m. talking about clinical pathways with you, Dave, and other PCBH things, talking about where primary care needs to go. We have wonderful conversations about that. So I'm excited for those side conversations and connecting with people. That's what I'm most excited about.
I still remember, I couldn't agree more. And obviously the content that CFHA puts out is great. And at the same time, what drives me about CFHA is just, as you said, those conversations. I still remember, I think it was us in Rochester. We were in the lounge or the bar area. And I think we were talking about, like, is there evidence for helping people lose weight and primary care?
Right.
And I think somebody even came up and was like, oh, this is such a great conversation. It's just, so related to that, and maybe this will be the final question that we end on. You're involved, as you said, like in every single, if we think about all the different arms that are in, primary care behavioral health, whether it be clinical work, whether it be training, whether it be administrative, whether it be research related, you're involved in every single one of them. So I think you're really great, that you're a great individual to be able to answer this question. Is that, what do you hope, PCBH, over the next 5, 10 years, either one focuses on or potentially evolves to? What do you think the next 5 or 10 years should look like for PCBH?
I think it goes back to how people understand the purpose and function of PCBH, because I think it gets misunderstood to this day many times by people who are doing PCBH work. And what I mean by this is there's a lot of this back and forth between COCM and PCBH, COCM, PCBH, and the purpose and function of different types of integrated care, especially for these two, are quite different. And so that is why they do complement one another well, because the function and purpose is different. When I hear, especially, I've been doing a lot of work on the policy front for the past year on some of the integrated care bills that have been presented to the House. And so being a part of the rewriting process and informing our Congress people has been awesome, but also a misunderstanding of what PCBH is. So I've done a lot of re-education to them about what we're doing. And so what I find is that I hear a lot of, well, PCBH needs more research. It needs more research. It doesn't have as much research as COCM. And I think people are missing the point, because PCBH is not an intervention in and of itself. It's a way of doing care. And I always share with our family medicine residents is, do you ever see someone say, well, family medicine doesn't work, we need more research? That is stupid. That doesn't work that way. Family medicine is a specialty. Like you might go within the specialty and say, we need better treatments for diabetes. We need better treatments for chronic pain. Couldn't agree more. We do for primary care. Same thing with PCBH. Within PCBH, we need better treatments for, we're getting there with PTSD. We, Greg Beeler presented on the CBT for chronic pain pathway last year at CFHA. We're definitely getting there. Katie Kanzler and her FACT protocol with Patty, we're definitely getting there. But I think when people can understand the difference between PCBH as a system of care versus the interventions within PCBH, they'll understand it's not a PCBH versus COCM. That's not the argument. It's really never been the argument. And it's frustrating that people have left it there. And so I would love to see a better understanding of what primary care behavioral health is for people within PCBH, because I think the PCBH folks don't get it either. Some of them don't. But also as we educate policy folks, educate our insurance payers, educate especially our Congress, who are passing legislation that will impact what we do in primary care. I would love for that understanding to happen, where it's not PCBH is the system, and then we do things within the system. Let's focus more on that versus PCBH or COCM, which is it's the wrong argument. And so I think if that can be better understood, I would love that for that to happen.
I know you just made Bridget's day, because this has been this has been one of the things that she's been saying more and more lately, and I couldn't agree more. That again, everything you said today it gets me hyped in so many different ways. So Stacy, thank you so much.
Thank you for having me.
We're definitely gonna have to do part 2 to this, because I still have a lot of other questions. So my gratitude, Stacy. Thank you so much.
Thank you.